I'd like to especially thank our moderator for this session, Dr. Jen Hastings. As many of you know, is an assistant clinical professor at UCSF Department of Family and Community Medicine and consulting physician for the Health Improvement Partnership. Jen continues to work with SafeRx Santa Cruz, our substance safety coalition, and teaches and supports transgender health around the country. Jen is an incredibly valuable member of the Symposium Advisory Committee. It's a delight to work with you, and welcome. Thank you. All right, and we have another local expert that we've brought to the stage, and we're going to let Ben say a few words about himself. But Ben Geilhoef is a queer transmasc therapist, trainer, and consultant. He has contributed to policy reform for higher education institutions and school districts, county systems of care, nonprofit organizations, and larger corporations around gender identity, awareness, and inclusivity. Currently, Ben is developing an outpatient gender-affirming care clinic for Santa Clara County Behavioral Health. Before this position, Ben was the director of community-based clinical programs for the UCSF Child and Adolescent Gender Center, where he provided clinical training and consultation on gender diversity for professionals throughout San Francisco County. Ben also developed and taught the inaugural full credit course on psychotherapy with transgender and gender diverse clients for Santa Clara University's Counseling Psychology Master's Program. In private practice, Ben supports individuals of all ages with gender exploration.
Thank you so much. How amazing to be in person instead of on Zoom. Yeah. So before we launch into your wonderful questions, and thank you so much to each of you who submitted a question, and in particular to our students who are joining us today, we really want to hear some words from Ben specific to our LGBTQ community and suicide. And Ben has agreed to share a few words with us. And then we're hoping that we'll put together some resources that will go on the Calciano website for resources specific to LGBTQ folk. Thanks, Ben.
Thanks, Jen. Thanks, everyone. I'm so happy to be here. Thank you for having me, Calciano family. And thank you for setting up this conference, 25 years. When we talk about discrimination and oppression, I think about discrimination and oppression as trauma, so traumatic events, continuous traumatic events, which can lead to complex trauma. And we know that queer and trans non-binary youth, I'm going to use that terminology versus LGBTQ. We know that queer and trans non-binary folks experience significant ongoing discrimination. And we're quite lucky here in California. We have a lot of legal support for gender identity, for sexual orientation, for diverse identities within that queer and trans umbrella, but other states are not so lucky, so I just want to call attention to the attacks that are happening specifically towards trans and gender diverse youth across this country right now. So bans on access to medical affirmation, medical care. There are some bills that are trying to take youth away from affirming parents and caregivers, so caregivers that support their trans non-binary youth. And when we think about access to resourcing and resilience, even though we're in the state of California, our youth here hear about these attacks, and it's an impact not only on safety, legal safety, but also on identity. So what is that message saying to folks hearing, wait, so folks with my shared identity, and I'm going to include myself in community because I identify as a queer and transmasc person, what does that say about me as a human when my identity is being challenged legally, politically, right, at a national level and really at an international level? This is happening across countries as well. So when we talk about these types of discrimination, we really want to understand what's happening on a broad level and the impacts of this, including really high mental health distress, anxiety, depression, and increased suicidal ideation. And we also want to think about how do we give access to resilience and the compass that you were talking about, which I really appreciate. How do we increase access to that life force? And that is building universality or shared experiences, supporting folks and getting access to role models like them. And social media is great for that, although I do think that social media can also impact us in negative ways as well. But really careful cultivation of positive role modeling in social media. We are lucky that in this day and age, we can connect with so many different types of folks within those trans and queer communities and see folks living, and not just living, but thriving, right, within queer and transness. I'll say briefly, California is now a sanctuary state for trans and non-binary youth who have been denied access to care. And I think just yesterday, Minnesota joined us. So that's 2 states. I want to bring numbers into this as well. The Trevor Project, which has already been talked about today, the Trevor Project did a national survey on LGBT mental health, and they found that 45% of LGBT youth have seriously considered suicide in the past year. That is almost half of respondents. More LGBTQ youth of color reported suicidal ideation than their white peers. And they also found that nearly 1 in 5 trans and gender diverse youth thought about suicide in the past year, 1 in 5. So these are really staggering, really problematic, troubling numbers. And so whenever we talk about services, I want to call special attention to queer and trans non-binary communities. How do we build in really queer affirming and really gender affirming resources, which is why I'm so happy to be building a clinic specifically for trans and non-binary, gender diverse, gender expansive folks ages 5 and older within Santa Clara County.
Wow.
Wow.
The last piece that I'll say, and I'll hand it back to Jen, is building resiliency is really about holistic wellness, which has already been talked about by other panelists today. Holistic wellness. So in each area that a youth navigates, their school, their home, their caregivers, their extended family, when they come to the Coconut Grove for a concert or a conference, sports teams, everywhere that they navigate can be harmful or can be affirming, and anything in between. And as professionals, providers, educators, clinicians supporting these youth, we want to assess every system that a youth is navigating for affirming resources. I think I'll pause there. I will say a couple resources, and we will post this to the website so you have them. I wanted to make sure that you all know the Trevor Project offers not just call crisis support, but text and online chat, which is huge for the youth that I work with, right? They're not calling anybody, they're texting them. The Trans Lifeline is a suicide support line staffed by trans non-binary folks for trans non-binary folks. So this is by community for community. Santa Cruz specific resources, we have the Diversity Center, they're here, they're tabling. The Lionel Canto Queer Center, that's UCSC. sctrans.org is a website that Jen and many other folks here in this conference have been instrumental in setting up.
Andrea Damon and Michelle Brandt.
Can you say those names one more time?
Andrea Damon and Michelle Brandt, thank you for your work on the website.
sctrans.org is a website with holistic care resources for gender diverse folks in Santa Cruz County. Mental health, medical health, community groups, talking about adding massage therapists, right? Holistic health, building out holistic health for these communities. So we can post these to the website that you have access to them, and I'll pause there. Thank you.
Thank you so much. So I just want to say one more thing, just a thank you to Nick Calciano for that beautiful introduction. And I wanted to honor specifically your vulnerability and today with us. That allowed me to really sink into both my grief and my hope. And these questions are so rich. We're really lucky that our planning committee decided to give so much time for questions. And I'll be watching the clock. If our students have additional questions, just let me know, because we want to elevate your voices today. And thank you for joining us. Okay. All right. So I'm going to stay with the issue of gender and sexuality. You mentioned, and it's okay I say Christine,
Yes.
That states were pulling out of the youth, let's see, what was it? Risk behavior survey. And was that specifically, is that your sense that that was because of LGBTQ issues, or the stigma around mental health, or both?
My sense, is this on? Okay. My sense about, and I don't want to overstate it. So far, there have been 2 states that have pulled out. But we look for those sort of early warning signs in a way of very disturbing changes happening. My sense is that at least in one of the local regions where this occurred, critical race theory was the starting point of polarizing discussion around what needs to come out of the school environment. And then from there, mental health somehow got lumped into this category of the idea of topics that need to remain in the family environment versus be in the school environment. And then the YRBS, which is a far-reaching survey of high schoolers that gets into any kind of, risk behaviors, meaning smoking, reckless driving, unsafe dating practices, like a whole host of queries, but also definitely includes experiences of bullying, trauma, suicidal ideation, substance use. All of those are part of the YRBS. So it's broader than just mental health. But my feeling is that mental health was getting lumped into almost being like a straw man, like being used in a way as a something to gain more rights for. And so, I think what we would like to propose here in this room, this may be a group with many diverse backgrounds, opinions, and politics, but what we want to think about is what are our priorities? And if our priorities are the well-being, growth, and affirmation, and to promote the health and development of our youth, then we need to look at things through that lens and in a way forget about our politics and think about what matters in the end. So that's and I know we all carry our bias, but that's my view.
Thank you. And just for all of these questions, anyone on the panel is encouraged to share. So DeQuincy or Ferris, if any of you have additional comments, if you're going to say the same thing, then please don't. But if you have something different to say or additional to say, that would be great.
There's so many questions.
Yeah, there's so many questions. So I think Ben mentioned the potential positive impact that social media has, and we got quite a few questions asking about social media as a risk factor for youth suicide. And so there are a number of questions that relate to that. Has there been any research about social media response to suicide and increase in suicide contagion related to that? If so, are there any suggestions? And I'll just read a few more. What role does social media have in contributing to suicidal ideation or suicidal attempts and suicide completion, especially for youth? And any ideas to address that? So I think we'll start with those, and maybe DeQuincy, I don't know if you have thoughts on that first, or if you, Christine, or anyone else.
Maybe I'll open it up, and then please chime in, because it's a big topic, and my apologies that I didn't mention it in my plenary session. It was almost like something's got to give, and but it is so important. So, we need, again, I'm sounding like a broken record, but we need to rely on what research tells us and lived experience. And so, the youth in the room, the students in the room, those of us who have vulnerabilities and use social media, all of that, and the research matters. And what I will say is it's a super growing area of of the research field, looking at both mental health and suicide-related impacts of social media utilization. But I will tell you that amongst the fairly niche field of researchers looking at it, they're using all kinds of methodologies, some of which are actually considered quite weak methodologies, meaning survey studies, where you just simply ask somebody to reflect back on their experiences and what led to what. And that is important information, certainly, but it's not the same as designing a study with a hypothesis and following a cohort of people prospectively, meaning now through time, and monitoring and studying their experiences, and ideally with a control group. That's the strongest kind of methodology. And so those fewer studies that are using that type of method to take a look at that is showing a whole mixture of results, a whole lot of negative results. So for example, when it comes to body image, anxiety, depression, fear of missing out, there are algorithms that we know on social media platforms that absolutely utilize human nature for their profit and not necessarily with the concern as much for the individual user, particularly those with vulnerabilities. That line of research is leading to some policy actions like COSA, the Kids Online Safety Act, that has not yet been introduced at the Senate, but it will be, and it will be if we and other organizations have anything to say about it. And then cyberbullying and exposure to graphic, even suicidal behavior and so forth. Those are extremely dangerous parts on social media platforms. So there's all of these negatives, and in a way, when De Quincey was talking about how trauma, one experience can have this enormously positive result with post-traumatic growth, and also have an enormously burdensome and negative result in terms of post-traumatic stress symptoms and disorder. In a way, it's like that with social media. It is a tool, it's an experience that can have both positive and negative, because we do know that for some marginalized communities in particular, they are finding community and connection and resources on social media, and a way to engage and connect. So I'll stop there and let others.
Just anecdotally, I think our schools are seeing kind of a whole shift of the bullying environment onto social media, and so it takes up so much energy and time to research, especially because sometimes it's taking place, after hours or over the weekend or whatever. But it has such a huge toxic impact on the school environment. And a single incident, you fall and do something embarrassing or whatever, which before was witnessed by 5 people, and people would talk about it, is now being shared. And obviously, it's not just people falling things are being shared. We're also seeing increases in incidents of anorexia and bulimia and other kind of body disorders. Also self-destructive behaviors that seem to be closely tied. Obviously, we need some research to look at causality, but closely tied to issues of body image that are coming from social media. So it's something that's of great concern for us.
Thank you. So there's a question that maybe you can just do briefly, any one of the folks here, maybe Christine, but is there any research on the kinds of messaging and imagery on posters and ads, and you created one, your organization created one, that most likely encourage at-risk folks to call 988 or otherwise reach out for help? I see happy smiling faces, sad crying faces, serious expressions, different taglines. I'm just wondering who decides on images and messaging and what that's based on.
I just quickly jump to the social media one because I didn't have a chance to respond to that. There was a news report recently that Billie Eilish had deleted all of the social media apps from her phone. And I think that that's one of the things that's really telling about the possible impacts of social media when people who are have a big following and lots of talent and lots of things going for them are still impacted by all of the negative comments and negative things that happen on social media. On the opposite side, though, I had read a research paper once about the dynamic spread of happiness and joy as a social network model. It's possible for social media to play a good role, especially when there are protected communities and standards that are being implemented. So some of the most positive social media things that I have been involved in are things that are more closed groups, but social. And so I think that there are possibilities for social media to play a big role that's positive, but especially the way that things have been with algorithms and with just the open nature of it, and with the quick spread of things that might be false, and then those are promoted. There's a lot of pitfalls as well with social media.
Thank you for that.
Andrea, Suicide Prevention Services, and I would say for the images that we're using from 9/8, they come down from Vibrant, they come down from the national campaigns. And what I would really like to see, and I like to work with the schools in this, is as you put together your youth leadership behavioral groups, I would like to see the kids be much more involved in designing those graphics, as they are with Directing Change and those videos that are coming out, which is a very cool website, by the way, if you haven't checked it out. So it's kids who are putting together videos around suicide awareness prevention, and they're very impactful, but that's really what I'd like to see. And I would also like to see, in terms of as we build this continuum of care through behavioral services, that we make sure that we include our young professionals in this transitional time so that we're filling the bench, and so that when some of our older folks retire, which we've seen a huge exit lately, we do have folks who have been trained and have been included in the process of developing this larger design and vision as we move forward in the next 5, 10, 15, 20 years. So I just want to give a shout out for the young folks.
Absolutely.
Can I just tag on to that? There is research that has looked at messaging that's, in graphic form, but also like plot lines, storylines, both news reporting, but also entertainment content. So there's several centers that study storytelling and its impacts on mental health and suicide. And basically, what we were talking about in terms of contagion before can apply in the positive direction. So when people see a peer or a role model who is getting therapy or disclosing about their struggles and how they're coping in positive ways, that inspires others to hold on to hope, to take their next step. Normalizing mental health services and treatment is a biggie that messaging campaigns and even like entertainment content can promote. And there are some content creators in Hollywood that are looking at incorporating those kinds of aspects into their storylines, particularly for marginalized communities, to really break through some of those cultural barriers or stigma in the way. From a suicide prevention standpoint, there's a lot of attention, for good reason, on the experience of loss and on suicide deaths. And of course, we need to be very, very focused on mortality reduction. But when it comes to storytelling, stories of people who live through their suicidal experiences, thank you to Quincy and others for sharing, that has a contagion effect in the positive direction. So, and those are mostly untold stories. When we're contacted by news reporters, they are usually not thinking of the survival stories and the hope and the resilience, which I guess it tracks with kind of reporting in general. But I think some of the more savvy media folks are actually aware of their social responsibility in their jobs in terms of these public health issues like suicide and mental health.
Just to add to holding the queer and gender affirming lens, how are these images cueing that these services are gender and queer affirming? So thinking about folks in relationships of all types, like polyamory, and then cueing things with like trans flags, So many different ways to cue that this is something that folks have been thinking about, and these services will be welcoming and will be knowledgeable about how to support all gender identities and all sexual orientations. And that's something that community does not know, and that trust has to be built around that, which is why it's so beautiful to have the Trans Lifeline, which is by community but for community. But I think the overall goal is to make all services for all people, right? This isn't just about cis folks versus trans non-binary folks. This is about all folks.
Thank you. So one of your comments that you just made me think or brought up this question that's for De Quincy. Can you speak to why or how the means of suicide can be personal or meaningful to the person considering it? So kind of using the challenging experience of a suicide ideation or attempt to, I mean, your whole talk was on suicide growths, but talk a little bit more about that.
Yeah, wow. I think the one that comes to mind most readily that's not crossing lines for safe messaging is the times where I felt like my voice was being stifled and thus chose hanging as a possibility. As kind of an illustration of it or a meaningful aspect of that. I've also seen that from others, especially when they choose the location and the method as well. So all of those can be final communications that are beyond what a suicide note might have. So some of them are communications within the method itself. I think that some things might be a little bit less conscious choices, such as if somebody is experiencing really damaging thoughts and they do something that is kind of gauged towards ending those thoughts as soon as possible or ending thoughts as soon as possible. So something that might involve brain trauma to some degree. I think that there are lots of ways that people might have an attachment based on particular things that they had seen or read, and then definitely if there are things that have happened within a particular area, so like Golden Gate Bridge, for example. I think that all of those might be ways that people might attach to something that is really specific.
Thank you. And just pursuing this a little bit more, there's several questions about what to do when you're working with someone who is very reluctant to work with a safety plan or is very attached to going south as opposed to north. You just can't move them out of that kind of framework. You mentioned going to sleep as a possible solution, but can you talk about a few other or proposed ideas?
So I had, to some folks, recommended the site nowmattersnow.org, which was developed by a colleague, Ursula Whiteside, that focuses a lot on DBT skills. And so some of those are things like the ice water approach. But her entire focus is on quick skills that people can use, and the site has lots of videos by people who have lived experience and have used both the coping skills as well as have experienced the suicidal thoughts, talking about how do you do this type of skill, how do you put this into place. I think that something that I might add to some of those is to individualize it. So for example, when thinking about sensory awareness or things that people might use to engage their senses, going a little bit deeper when possible to notice what their primary sense is, if they prefer something that is visual or something that is more tactile, and then working from there to the thing that they most associate with life within that context, and then having that be super available. So for somebody who is tactile, it might be some fabric that reminded them of somebody who was really meaningful or something like that. But it's something that is then very personal and will have an immediate outcome because it'll quickly get to the center of the brain that is connected to that being kind of life-affirming. Those are the things that come to mind immediately.
Thank you. Can you say that website again? Because I didn't.
Yes, it's nowmattersnow.org.
Now Matters Now. Thank you. Great. So there were several comments and questions about addressing the immense stress that youth are feeling around school, especially around the message of getting to a university, getting all A's in order to be a meaningful sort of person in the community. And so there are several questions about how to address that kind of systemic stress, actually not just on the youth, but also on the teachers. So I don't know, Ferris or other people on our panel, Andrea. It's a toughie, right? How do we do, it's sort of so deep in our culture. It's almost like the white supremacist culture too.
Perfectionism.
Yeah.
I mean, I think that one of the impacts of the pandemic has been a certain amount of isolation, and it creates the illusion that we're all alone. And I think that that's, I'm not a clinician, but my sense is that that is one of the kind of core aspects that really exacerbate or amplify distress and anxiety. And I think that bringing youth together, having peer counseling type programs is something that we're looking at expanding throughout the county. One, because students are able to talk to each other, and then maybe will talk to each other first before they talk to an adult. And if they can be trained and learn some skills, they'd be able to work together to have somebody side by side to be able to kind of work through, connect to some an aspect of life that they celebrate and enjoy. And so I think one is kind of expanding that sense of awareness that they're not alone, finding ways for them to connect with other youth who have some skills to be able to really build a sense of community. And I also think that a parent education component is also extremely, I mean, I have to, it's, as a parent, it's hard, I have to catch myself as I am reliving the same trauma that my parents and expectations they put on me. I was supposed to be a chemistry major, and I was supposed to be a chemist right now, right? And here I am talking to you. And so not putting that overlay and learning what I need to do to make sure that I'm giving the space and the love, the unconditional love to my children. I think that's something that we all need to learn and remember. So from a layperson's point of view, those are the kinds of things I think we could do at the school to help create those conditions, that environment that would reduce the anxiety levels and also give them some tools to be able to work through them.
Thank you. Ben, you want to go for it?
I just wanted to add something that we saw, clinicians in the gender world over the pandemic, which was really interesting, but it makes a lot of sense when we think about it. So first of all, we did see absolutely trans and non-binary youth who felt the isolation, who had the increase in depression and anxiety, a lot of increase in distress and symptoms. We also saw folks who had a decrease in distress due to not being in school environments, due to not having to decide what bathrooms to use, or having to navigate being misgendered consistently, or who to come out to when, or being bullied. So there was almost like this grounding release of breath and a pause for folks, and a withdrawal into the Zoom world that actually felt safer. So I wanted to name that, and I'm curious if that was underneath some of the data that you shared, Christine, from 20 to 21, there was a decrease in suicidal ideation or attempts. So I just wanted to name that as well, and thinking at how important our environment is in impacting these symptoms of distress. I think that is what we have just been through, gives us a lot more information about trans and non-binary communities and youth living through constant discrimination.
Thank you. That's really important. So Christine, you mentioned inflexible thinking and perfectionism as a risk factor. And so we have and in this person's question, they are asking if you see a connection for ADHD kids or autistic or neurodiverse population and suicide risk, and how might we help support our neurodiverse youth?
Yeah, thank you for raising that. I was remiss in not mentioning that there is actually relatively new research that we didn't even have like 5 or 7 years ago that is actually finding that ADHD and autism spectrum experiences do elevate risk. And it was always kind of clinically intuitive in terms of the struggle that those experiences add an extra layer of a burden for children to have to deal with. But it actually came out in one of the analyses of suicide deaths of youth that Jeff Bridge led that study on, that actually showed that ADHD was rising up as a true risk factor that we hadn't seen before. Same thing with autism. Those were actually some of the same studies where we, for the first time, it was noticed and revealed that Black youth and youth from underrepresented backgrounds were showing these disturbing trends. You know, white people have always had higher suicide rates, but now we are seeing actually some reversal in some communities. Those are some, it started pre-pandemic, but then it was actually accentuated and kind of heightened during the pandemic. So anyway, that's getting more into race. But it is true that for youth, with the thing that's challenging about youth and suicide, risk factors per se, is that when a person is young, their mental health experiences are evolving. And so what might later, let's say in late teens, early 20s, become definitively diagnosed as, let's say, bipolar disorder. That's one of the kind of classical situations where when they were 8, it looks like ADD. When they're 10, it looks like an anxiety disorder. And it kind of keeps evolving in certain instances. And also remember what I explained about that half of mental health conditions present by age 14, but how many times are we missing that? Because we are writing it off to, well, it's because we're in this stressful circumstance as a family, or they switch schools, or there's bullying going on, and so we're not recognizing that it is a diagnosable and treatable mental health condition, and in the setting of all of those, social contexts. So, I think all of that needs to be considered, but definitely thank you for highlighting the thing about ADD and autism. And it really just, I think for me, highlights the fact that there are human experiences that all youth are having that could be increasing risk, and we need to come around and come together on a supportive level to, in a way, normalize those things in a way. I mean, that's weird maybe coming from a psychiatrist, but normalize it in the sense that we all have health issues. We all have, traits like inflexible thinking or perfectionism, that the more we can take stigma out of that, the more we can encourage each other to see it for what it is and take healthy, proactive steps to address it. We get in our own way about that. The thing about perfectionism, I'll just say one more thing about that, is that it's, again, like any risk factor for suicide, it's not that it's always there. But when it is there, and I think about certain populations in our nation who are at higher risk. Among occupations, there are groups, believe it or not, like physicians and nurses that have higher suicide rates than the general population. And part of it is we get in the way of our own health and thriving because we are so rigid about our identity as caregivers that to admit our own vulnerabilities feels impossible, and we feel threatened by it. But I will tell you, being somebody who came out about all of my own lived experience, long time ago, it is so empowering when you get on the other side of that, where you're kind of freed up to be vulnerable, to be fully human, and to help others and see that we're all in that together. So anyway, I got off on lots of tangents on that one.
That was beautiful.
If I could just add, the part of the question was about staff, and I think that is another aspect of, we're so kind of student-centric, which I think is great, but the fact is that when a traumatic incident takes place, there was recently a situation where there was a shooting at a party in one of from students from a school district, and Michael Painter and a team of folks put together support to go to the schools and provide support for students who had either witnessed it or were somehow connected to that shooting. And one of the things that we got some messages from were from people who had had the students, either the student who had done the shooting or the student who was the victim, who had known them when they were in elementary school, and they said, "Don't forget about us." And I think that this aspect of us remembering, making sure that we are providing that space for all our staff and kind of recognizing and honoring the amount of selflessness that goes into this work day after day with students, and creating, letting them know that, that they absolutely have to take care of themselves, and providing the space and support and care for them to take care of themselves is a fundamental part of this work.
Thank you. So you mentioned kind of the earlier spectrum that may move over time, and there are a number of questions about our needing to pay attention to our elementary and middle school youth, and can we develop programs for them? So maybe, so one of the questions asks, what data and resources are there around this earlier population? And I think that's a whole, hour talk probably. So to both of you or anyone else on the panel, how do we want to move forward in really identifying, screening, finding resources for our younger kids, elementary and middle school? So you're on the spot, Ferris.
Well, I think that a lot is being done, but we still have the same limitations we've discussed earlier in terms of numbers and resources and funding. When Encompass and PVPSA and other resources, they do provide services at the elementary level. There is a bigger focus on the high school level, and just because there is, I think it's more at the intervention level perhaps, and we need definitely more of an investment in prevention. We often get asked, why are you putting wellness centers at the high schools? Why aren't you putting them at the middle schools, or why aren't you putting them at the elementary schools? If you prevent it early enough, then you won't need them later on. And I think we need them everywhere. I think we need to have that kind of support and that prioritization of wellness everywhere. But we feel like we want to stop the next suicide. We want to stop the next acute situation. And we recognize we have to start somewhere. We have to keep our focus, on what we can achieve right now, but we absolutely are looking towards building more and more of those resources. And with the changes that I described, with the ability to charge for commercial insurance, which is coming down the pike, our ability to be able to get reimbursed for those services will allow us to be able to invest more in bringing more clinicians on board, and I think that's necessary. And also, we need to continue to provide that Tier 1 support so that everybody who's interacting with young people at all levels has some skills and is able to create that culture of belonging that we want.
Thank you.
A little outside of the box, but in terms of being able to identify things early, I think that we are learning more and more in terms of genetics that kind of allows us to understand a little bit more about what's happening inside that ends up looking a little bit different, so that it ends up looking like ADHD in some cases and bipolar in other cases. So for myself, for examining which medications I ended up being the most responsive to, and then looking backwards as to which biological systems those seem to be connected to, ended up looking at the same genetic markers and the same neural systems that would also be associated with other conditions that have been identified in my family, such as substance use disorders, such as ADHD, such as OCD, such as some of those spectrum aspects. So I think at some point we will be able to identify things either in terms of the genes or in terms of what that looks like early on. That will enable us to more specifically target what is happening inside without having to give it a particular disorder name, but just know that we are going to have some sensitivity in their dopamine system. And so we might want to increase their access to this or to that, instead of having to wait until we have enough of the symptoms to give them a syndrome. And then responding to that, I think in the future, as things keep progressing, we will be able to identify those types of things early and get a jump on it.
Yeah, thank you. So I want to elevate one of our student questions, which is very concrete, and I'll connect it with a question from another person who didn't identify as a student. But the question from the student is, what can schools do to relieve anxiety and stress when coming back to school after a suicide attempt? And the related question, I think, is how can we create and follow through with a meaningful post-vention, which was the terminology new to me today, post-vention curriculum. How can we develop that? So I don't know if you want to talk, I don't know if that is a resource on the website of a post-vention curriculum and the steps we could do in Santa Cruz for that.
I could say what we have, and you can say how we can make it better. Michael Painter works with all our student services programs across the county. So we have representation from, and they worked on a suicide prevention plan manual for all the districts, both for prevention, intervention, and postvention. I think we don't use a consistent curriculum for postvention, but there's different kinds of kind of evidence-based programs. I think More Than Sad, which I think is from AFSP, and a variety of other programs, the Trevor Project and some other programs. And so having those that we do have plans in place, and I do think that being able to recognize, I think as I heard in the presentation, that we could think about the short-term effect of the impact of a crisis and forget about that long-term, and we can't do that. And so I think that working with the teams at every single county has made every single district in our county has made a commitment to make sure that they have the training to be able to both prevent and respond when we have a suicide take place.
As for the specific moment of returning back to school after being hospitalized or needing to take a leave of absence for any mental health reason, including after a suicide attempt, that is a very specific and important moment in the continuum of the model school district policy on suicide prevention. And I think what it would look like ideally is where you have trained, caring, compassionate staff and somebody who is communicating with the student and with the family as appropriate, and explaining what is happening and following up with them after they come back. I think if you think about it in the big picture, these are health issues. If you get hospitalized for pneumonia, let's say, when you come back to school, there is a plan in place with maybe some academic accommodations, the allowance for catch-up academically, and just general support. And so how do we apply that same framework to mental health and suicide, with the understanding also that because of the stigma that's there still in society, there will be a higher likelihood of embarrassment, shame, who knows what information, and just having that anchor, that trained staff member who is able to follow through with this is enormously stabilizing in that moment where it feels really scary and uncertain for students and probably for their parents and caregivers.
Thank you. And then another student question that has
add on really quickly
yeah,
for
thank
that?
you. Yeah.
One thing that I believe the model school policy also has information about social media, especially for what the school should do in terms of promoting media. So I just wanted to mention that the model school policy has lots of information and lots of things that can be borrowed from. Yeah. The other thing is in terms of, let's see, what were we just talking about? Oh, it's skipping my mind.
Oh, that's okay. It
Come
happens
back
to
it.
all of us. If you think of it later, go.
Or return to school.
Return to school.
The other thing that I just wanted to quickly mention is that there are some specific discussions out there, guidance around navigating issues between FERPA and HIPAA, I think, that come up that lead a lot of people into kind of tripping up what they can or cannot talk about when students are returning to school, what they can communicate about, and what is allowed within the context of promoting the health of a student.
Thank you. So kind of related to this, and as I was starting to say, a student question is, And Andrea, your turn. And County Andrea, I'm going to call you, instead of 988 Andrea. Where are the walk-in crisis units located for youth and then for adults? And a related question is, how does someone access MRDI if you're just a normal, regular person and not connected, especially after hours?
Great. Those are great questions. So we do have an 800 number at the county. I'll say it, but it's also on our website. It's 800-952-2335. And you can access our access services and our MERT services and MRDI services through that phone number. It operates 24 hours a day, but during work hours or during business hours is currently when MRDI is available. And how to access the walk-in clinic is, we have two clinics, one at 1430 Freedom Boulevard, and the other is at 1400 Emmeline. The Emmeline is in Santa Cruz, and the 1430 is in Watsonville. And we have walk-in hours also during business hours every day for youth and adults. And anyone can walk in. And you don't have to be in crisis to walk in either. People walk in because they want information, or they're concerned about someone else, or they bring someone else with them because they have some concerns. So we take all comers, and you will meet with a licensed clinician who will sit down and really hear you out. So, and it's open to everyone, regardless of your insurance status.
And thank you. So so you don't have to have Medi-Cal, you can have any insurance to access all those services?
Yes, you can have any insurance. And I wanted to say that a provision of the AB 988 is that it has a parity piece so that all insurances will be able to be billed for any kind of crisis services that the mobile team will be providing.
What did you say? What about no insurance? So if you're uninsured?
Yeah, uninsured is fine as well.
Okay, perfect. And then there are several questions asking about the news that the youth beds at the psychiatric or the partial hospital stabilization, the PUF, whatever that place is, that the youth beds are gone, and we have something maybe coming down the road, but what are families supposed to do?
I kind of knew that question was coming.
Okay, yeah.
So we do have a date. It's March 27th. That's the date that we will no longer be, they will no longer be accepting youth at the crisis stabilization program at the telecare site, the behavioral crisis center. That being said, we are actively working on developing an interim site before we will not have the youth crisis stabilization and crisis residential site open until the end of 2024. We just can't pull it before then. But in the interim, we are working with community partners. We're actively working on developing an interim site. We're putting out a request for proposals to get people to come in and run a site, and we're actively seeking a place to be able to do that. And we have a lot of people at the table who are all interested in supporting this. So we're going to get this on as soon as we can. It's not going to happen until probably the fall, though, I mean, realistically, because that's how long it's going to take to get through all of the hurdles. That being said, in the interim, I do want to say that it was only in 2013 that we had any sort of youth crisis stabilization here in the county. And before that, people did go to the emergency department. It will put a slight burden on our emergency departments, and we realize that, and we are in also communication with our emergency departments, with our two hospitals. We are doing everything we can to be able to support this transition, and we also do have MRDI going in every day that there is a youth in one of the hospitals, including weekends, to evaluate that youth to see if they can return back to the community as soon as possible without going into an inpatient hospital.
So a related question was whether there would be plans to provide training for the emergency room, because there's the experience that there's not enough trained folks at our emergency rooms right now. So that maybe is a suggestion.
Great. I love a suggestion. I'll
Good.
write it down.
Good. And so I just want to circle back to one of the responses you gave, because around people needing counseling who have private insurance or who are underinsured. So according to this, which I totally believe, this person who's writing the question, there's a 6-month wait for psychiatry if you have private insurance in this county, and probably longer, I'm guessing. What can we do? You're on the spot, Andrea. It's you. Sorry.
I honestly don't have a great answer for that. I mean, really, private insurance is not doing a great job at providing psychiatric care for youth or adults. And although there is mental health parity in the state of California, it's not as good as other insurance, as the medical portion of your insurance. And I don't know how to get around that.
I have one little thing. So, as I mentioned, pediatricians are getting more involved now in mental health care and in suicide prevention. And one of the things that, as we've rolled out training for them in caring for mental health and suicide risk, is the fact that in most states, and I believe it's true in California, there's something called the Child Psychiatry Access Program, which is a funded program that has child psychiatrists basically available for taking calls from pediatricians, so that if there are trickier aspects to a depression, anxiety, or eating disorder and so forth in the primary care setting, they can at least get the help and advice of a child psychiatrist in their decision tree around care. So don't assume that pediatricians are totally unable to, to be part of that care team. I know that puts burden on them, but that they are part of the care continuum for sure.
I also want to add that if someone who has private insurance touches our MERTI team, they will provide some therapy and case management until that person gets linked. So when we do respond to a crisis, and if there is a need for light touches of therapy and case management, we can step in. The MERT team will step in and provide that until they can get linked to a therapist.
Okay, that's good to know. So we have another student comment and question, and I'm going to read it, and thank you to the student who sent this. I have had quite a few hospitalizations due to suicide attempts and have been placed in telecare after medical stabilization. I have found they often make my mental state worse. How will these new crisis stabilization centers differ from those we had prior? Thank you.
First, I want to thank that student for your vulnerability and really stepping up and asking those really hard questions, because that is a really hard question. And I also want to apologize for the experiences that you had. I want to acknowledge that the site that is currently at our behavioral health center is not ideal, because it is a shared site with a youth portion and an adult portion. And every time a youth comes in, it pulls away one person to be with that person, and then lowers the number of people, the number of adults who can also be served there. So this is part of the determining factor. But for youth, it isn't a youth-specific site, and I think therein lies a lot of the problems. When we are able to open a youth-specific site, people will be youth-specific trained. They will be there to serve the youth exclusively. They won't be pulled away. There will be people there who are trained in serving youth. And the wonderful thing about having a crisis residential upstairs is that we're really expecting the number of youth who get transported to a psychiatric hospital. will be much lower because there'll be a safer place for them to go where they can be with other folks who are experiencing a crisis. They'll get that kind of support, but they'll also have the opportunity to just be away from the environment that's creating stress for them. So in a space that's safe, that's not out of town, where their parents can visit. I mean, I think we've got a win-win here, and I know that this is something that the community has wanted for a really, really long time. And although the timing is long and may not seem perfect, like, we are very, very excited about this new facility, and we absolutely want to hear from youth voices what will make this a better place for you.
Could you have a youth advisory board for this?
I will write it down.
Okay, thank you. Great, great. So there's another question from a student. And Ferris, this is specifically for you and Michael, who's in the crowd. How do we connect with the Companion Project? So you mentioned the Companion Project as something you've started, and I think Lauren Fine maybe is overseeing that?
She's the director of behavioral health. I would call the main number 466-5900, or no, that's my number, 466-5600. You could call me too. So the main number, and then ask for the Companion Project.
Sorry, what was the main number?
466-5600.
5600.
5900 is the superintendent's office.
Okay, good.
So if they don't get back to you in time, call the other number. And we'll be happy to talk to a parent, student, could be about somebody else, and see if look into it and see what we can do to help.
And what do we do? I have this question in my head. It's written down here. What happens when there's a student whose parent doesn't believe in mental health care and they don't consent to referral or treatment? So that might be to kind of all of you. What do you do?
It's also going to depend on the age of the youth. So youth who are teenagers can actually ask for care on their own. They do not need consent from their parents. And so that's one way for youth to get care. In a crisis situation, in a situation where where we actually have to write a 55-85 hold, even if the parent doesn't agree, it's ultimately the hold will take precedence over the parent's wishes, which is unfortunate. But we certainly try to work with every parent and guardian around that. But if it gets to that crisis situation, then that's what will happen.
DeQuincy or Christine, have either of you had experiences with this and can make suggestions?
Because I'm pretty sure in schools we serve students over the age of 14 a lot. I think that in many cases, there's certain protections that students have, and if it is a matter of caring for students, it doesn't. There's certain kinds of therapeutic support that we can offer without needing to notify parents.
I was going to say it's a bit of a workaround, but knowing which places and which groups have had training in ASSIST, for example, or some of the other similar trainings, might be a way to get somebody to a person who knows more about the issue. I think as there was going to be some training around mental health first aid as well, right, and youth mental health first aid. So at least getting people to somebody who is an adult and somebody who knows more about trying to navigate some of the mental health systems or mental health issues, I think can be something that is at least a temporary workaround if somebody's family is not necessarily saying, let's go to the mental health clinic.
I'll just add, if you are a school staff person and the parent is, initially presenting with this pretty hardcore viewpoint, I would not just assume that's the end of the conversation. I would keep on using any tactic we can in terms of education, giving them some insights about what might be a likelier course for their child with the mental health treatment and support in place, not only in terms of the mental health piece of it, but in terms of social, academic performance, all those other things that we know hinge upon a certain level of mental health being sort of, foundational for functioning and for development of youth and teens. So, I know people are busy, but don't assume that an initial resistance or no is it. Like I was somebody who, in my work with medical students and physician colleagues who were always refusing to go to the treatment that they needed.
Right.
I never gave up, and you bring them back in and you have another conversation and you appeal to what they identify as their concern, and that's the bridge to, to the help that they might then at least consider. And I know that's not going to work with everybody, but it can be more powerful than you think, even in the most difficult of a resistant situation. It's kind of like the situation when the person themselves is refusing to go to treatment. And as a family member or, again, a teacher, do not underestimate the power you have in their life to keep raising the topic and trying to explain it in different terms and hear them out about what their concerns are. It may be that they're making assumptions that they will ruin their career, opportunities if they get treatment, which the fact is, if you don't get treatment, that jeopardizes a person's trajectory much, much more than getting treatment.
Mm-hmm. Thank you. I think that's a similar experience with parents who are initially very negative in their approach to a trans and gender expansive child. You don't stop working with them, you keep on. Thank you. So we have a question for you, Andrea. We actually have a lot of questions for you with the 988, Andrea. Yeah, and you have more County Andrea too. You're not off the hook yet. So this is from a student, thank you so much. Does 988 deal with eating disorders, or is there a 24/7 number that you can call about eating disorders? Such a great question.
It is. So we do not counsel on eating disorders on our lifelines. We answer phones, for people who are feeling suicidal or having a heightened mental health crisis, but we do referrals. So we will, again, work with our callers to ensure that they're safe, we're listening, we're connecting, and then we will provide them with the resource. We'll either do a warm handoff or we'll give them a phone number and then we'll follow up.
And I know personally that eating disorders, addressing that it's really difficult to get care around that. So what are your referrals?
So what we work with 211. We're very close partners with 211 who are, that's what they keep that resource list very updated in terms of our community resources. And then quite honestly, if we don't know, we'll go online. We'll look it up, because again, we're the immediate access to those resources in terms of what's available locally. Where that data is collected and how we access those resources, again, we might just go online with the caller, or we'll call them back, quite honestly.
So I know that, eating disorders is in one of those areas that's both, no one wants to own it because it's a medical issue and a mental health issue, and so I know that it's really challenging. Yes, we have Lotus, but Ben's going to say something else.
Yeah, I was just going to say some resources if that would be helpful. So the Lotus Collaborative is an eating disorder treatment center that's local to here. They have a facility on Mission Street and then up in Castro. They are queer and gender affirming. They're for all bodies, all identities. They have an open community drop-in group. It used to be online. I think that's something to double check. Many folks that I have worked with don't want to just show up. There's a lot of nerve coming up around around logging on to Zoom with a bunch of people that you do not know to try and access support. And so calling Lotus to ask about what are ways, is there a one-on-one contact that the person can make first? Is there someone that can support them in accessing that service? I also want to name Fed Up, F-E-D as in dog, U-P as in Peter. This is a intersex and trans non-binary collective of folks supporting body image and eating disorder care. They have online groups specifically for intersex, trans, non-binary folks, and a lot of other resources. They also keep a national log of gender-affirming, gender-aware eating disorder providers and groups. So you can check out their website.
So let's put that on the website for the Calciano.
I'll
That's
add
great.
that, yeah.
Yeah, thank you.
I have one more national resource, NEDA, if y'all have heard of the National Eating Disorder Association, and they do have a helpline that's available, not 24/7, but it's like 12 hours a day that you can call a 1-800 number.
Thank you. And there's a related question, kind of, talking about kind of diet and the preponderance of kind of sugary food and chips and soda. That's basically what our kids eat, or a lot of kids eat for lunch. And the question for you, Christine, is does the low nutrient, high sugar contribute to depression, anxiety, et cetera? And how much training, I can answer that, not much, do physicians get on nutrition?
Yeah, very, very little, like maybe one lecture in 4 years.
If you're lucky.
My view of this is that it's probably an under-recognized sort of factor for many people, but I think there are physiological differences that where for some people and some patients I've taken care of, I know now I've been on my own kind of journey figuring stuff out for myself, that certain things like sugar, certainly gluten, I mean, we've become so much more aware in general, but when it comes to mental health, not as sophisticated. So I think if you're onto something for yourself, that can be part of your own self-discovery and learning journey, and you can find a mental health professional who is specifically trained. I know 2 colleagues, psychiatrists, who approach their practice with the concept of food as medicine as part of their psychiatry practice, as an example. And obviously there are many other types of practitioners besides psychiatrists that are even more educated about that important aspect. So I think there's absolutely something to it, and we don't get well trained on it in medical school in general.
Thank you. It's very true. And thank you for the questions. So here's another student question. This, I think, would be for you, Ben, and for me. If I have a family member who goes by they, them, how can I help make people take them seriously and know that it is not just for attention? Thank you for that question. It's really a struggle. Go for it.
What a beautiful question. Thank you so much. And thank you for your attention to thinking about how to help, and part of what we can do as allies, that's all of us, right, around, supporting someone who's exploring different language, is to take some of that burden and energy off of them, or all of it. But I often check in with someone, and I ask questions like, if I notice that they use incorrect pronouns for you, if mom or dad or moms use incorrect pronouns for you, or when we go hang out with grandpa or whoever it is, can I correct them in the moment? Would that be helpful? And wait to hear their response. Some folks will say, yeah, that would be awesome. Some folks will say, no, not yet, not ready there, not ready yet. Some folks might want cueing. I talk a lot about cueing. You already heard me name this, but we can do cueing through language as well. So I will be very intentional with the pronouns and words that I use in front of folks who don't use accurate language. So using they, them. Again, I would check in with your family member to see how that feels. So this is really consent-based around what would be supportive to them. There's just lots of different options. There's a whole list that Dr. Caitlin Ryan from San Francisco State University created about affirming behaviors for your youth and non-affirming behaviors for your youth. And psychoeducation can be really helpful too. There are so many resources for folks around psychoeducation. You do not have to create it on your own. So the affirming, like what does it mean to actually support a family member who is trans or non-binary? And you can print out those affirming pieces and put them on the fridge. You can have a conversation with your family if they're open to it. Again, if the other family member is open to it and it says that's okay. There's also resources for families that I'll name, because I didn't before, but there's the Trans Family Support Group, and they have chapters here in Santa Cruz and in the larger Bay Area. And the clinicians in the room, we all know, and me again as a queer trans person, I know that it can be really hard for a parent or caregiver to walk into a support group. And I know that folks will do one-on-one meetings. So go for a walk, meet for a cup of coffee or a tea with another parent or caregiver who's struggling. So that's another way to connect, to share information that's not resting on the family member. There is Somos Familia, which is Spanish-specific resources for family members of folks who are queer and trans non-binary, and they have videos, they have written resources, they have so many cool things. The last thing I'll say is be there and listen. That is so instrumental. Your time and your energy. Even asking, how can I help? And if that feels like too much or too big of a question, and it might, just be like, okay, well, just know I am here. If you ever think of something that you're wanting or needing, I'm here. Let me know.
Beautiful, thank you. And you mentioned Dr. Caitlin Ryan. So the Family Acceptance Project is the name of Dr. Ryan's program, and the Diversity Center and County Behavioral Health, and a number of us have been meeting for, I think, 2 years, and the Diversity Center has sort of spearheaded a proposal that we bring the Family Acceptance Project to Santa Cruz. And it's a big lift. We tried it maybe 8 years ago, and we just couldn't pull it off. It's a lot of money to do it. But just want to name that might help our community to have parents, teachers, et cetera, be more supportive. So thanks. So there's another student question. This is great. So the questions start, can 988 help parents understand services to help a suicidal adolescent outside of the county? And I think the answer is that 988 will direct you to the appropriate county services.
Correct.
And I sort of had this question about, what if my area code, because you said it's based on area code from the number calling, isn't where I live? Like, so many people have area codes from all over the place, not necessarily from where they live. So how does that work?
And that is a big issue with our geolocator, with 988.
Yeah.
So 911 does have some kind of a geolocator, which is why we do reach out to our 911 partners in terms of they can pick up where those cell phones are, based on the cell tower around that area. We get a lot of calls like other places, right? So again, we'll work, if it's imminent risk, that's a different issue.
Okay.
If we're just working with the caller, it doesn't matter where they live in terms of, we're still going to be doing the same risk assessment, connecting, being there, being present, offering support, and sitting with them, and to be able to de-escalate those callers coming in. If they're looking for local resources and they're out of our area, again, what are you looking for? How can we help you find those resources? And I think what happens a lot is that we get stuck, and we really are focusing on, which is an incredibly important thing, is around what happens when there's imminent risk. And that's where most of the discussions, a lot of the discussions are happening right now within people who are serving, for people that we are reaching out to or we will reach out to in terms of how do we respond, who's going to respond, and how do we make sure we're connecting with the right people. And we're spending a lot of time working with Andrea in terms of what does that look like locally for our mobile crisis units? What does it look like in terms of countywide? And with our other county partners, San Benito and Monterey as well.
Thank you. And this question kind of has a part two to it, and I'm not sure that you'll be able to answer it, but I think it's a great question. So it sounds like the person they're concerned about is in another county that has very limited services. And so is there a safe way to transport an adolescent to facilities outside of the county they're in instead of going through the emergency room? So it might be that I encourage that person to talk to you personally, maybe, because it sounds...
Yeah, it sounds more complicated.
Yeah. But I just want to thank the person who asked this and encourage you to talk to Andrea one-on-one. I still have a zillion questions, so I'm going to start, because we have 15 minutes so I'm going to start going bing, bing, bing. So we did the area code 1. What's the average length of time for a 988 call?
So we limit our callers, again, you know, we can't stay on the line all day long, which a lot of our responders have a hard time getting off our lines because we're so compassionate, we're so caring, but we really limit our, if we've already determined it's not an imminent risk, we've just got de-escalated them and working with them. It's anywhere between 10 and 20 minutes. We do go up to 40 minutes with our calls, depending, of course, in terms of who we're working with and what the discussion looks like.
Okay, and this person said, well, I'll do a quick one. Do you have a local Spanish-speaking and bilingual response?
We do.
Yay.
Yay
Good.
for us.
Good.
Yay.
That was good. That's the right answer.
We do. And we just hired a bilingual education outreach staff person to be able to go out and do our presentations and answer those phones in Spanish.
Is there or will there be an alternative for for 988 for deaf people?
Good question.
All right. Thank you, whoever asked that. Put it in your notes.
Put it in my notes.
Yeah.
I'm writing it down.
And then in 2017, when I called a suicide hotline multiple times for a friend, I never got through to anyone. How many people are on hold?
So again, because we are, for us locally at least, we've staffed up so people are not on hold. So our answer right now is about 82% to 85% of the calls coming into our lines. Back in 2017, you know, it was different. Let me just put it that way. You know, for us, we had volunteers on the line, and now we have staff members. We're better funded, so we can answer those lines.
Got it. And I'm glad, yeah. So this, I don't know if you can answer this quickly, but how are the police department personnel involved in the calls where a person is in imminent danger? Is there a group that doesn't wear a badge and carry a gun to come with calming care to help do triage?
Not yet,
Not yet. Okay.
but it's coming.
It's coming.
Yeah, this is what AB 988 does.
For Andrea, how can a client get a domestic, so Andrea County, I believe, get a domestic violence hotel voucher after hours?
So all of the hotel vouchers are through Monarch Services.
Okay, so they
And
contact
I do want to
Monarch?
say too that grant that Monarch was using actually ended. We got a no-cost extension, but it may be that Monarch has used up all the vouchers from that grant now. That grant officially ended on January 29th, but we're still able to use some, if there's funds left over, we're able to use them into July. So that would be a Monarch question.
A Monarch question. And you're saying that the Monarch grant ran out?
This is our Building Hope and Safety grant.
Okay.
It's a suicide prevention grant that has a chunk that Monarch Services got to give vouchers.
Great. So maybe we can, when we get the answer from Monarch, we can put that on the website too. I don't know, it seems really important. Several people asked, how common is suicide with no idea or warning by loved ones? Such an important question. You want to take that, Christine? Or?
I mean, I think it's really common to not see it coming and to feel in the moment of loss or in the acute aftermath of loss that it was a person and a family can feel 1,000% blindsided. And, you know, because we at AFSP and also many of you in your organizations work with suicide loss survivors, and we do all across the country on an ongoing basis, we hear what happens then next, which is oftentimes as they learn more about suicide risk, they may then go back and start thinking about what might have been some behavioral signs and changes that were not interpreted from the lens of suicide risk. We're all learning as we go. No one can do that perfectly. It's very challenging to do, even for those of us who are super expert about this. So I think the experience of it is very common, to feel blindsided. What we believe is that if we had a magical way of understanding that even sometimes the most subtle indicators of behavior change, because we're so zipped up, we mask distress. But if you think about it, tone of voice, hopeless words being thrown in. Most people are not coming right out and saying, hey, Mom, I'm now having thoughts of suicide. But they might be sleeping more, withdrawing from their activities, things like that. So, I mean, I think there are cases where it is incredibly impulsive, and there really weren't those sort of neurovegetative signs and changes happening in advance. But as part of suicide prevention efforts, we certainly feel the need to try to educate people as much as possible to not write off what you're noticing. We say trust your gut and don't assume someone else is going to approach them. Engage them in a loving, supportive conversation just to open up the dialogue. And then really the question to ask them is, or the thing to say is, this is not about judgment. It's simply, I want to understand more about what you're experiencing so that I can support you better. And that's an invitation for them to open up if they're ready to about what is going on in their minds.
Thank you. The next question is about lethal means. And actually, there are a few on this. When addressing access to lethal means, should one focus on the patient's identified lethal means, such as pills or other, or should you also address things that you don't know that might be there, such as knives or hanging or guns?
If you're a clinician, then you may have worked with your patient very specifically around their suicidal thoughts and plans, and that can guide the safety planning and lethal means counseling conversation you have. If I'm a person whose friend tells me about their teenage child that they're worried about and who's struggling, then I say, number one, make your home environment as safe and secure of all lethal means as possible. So that can include, household cleaning things and medications, as well as the obvious things like firearms and other toxic, medications.
So 2 questions, or actually 3 more on lethal means. Is there a legal place for a youth or adult to surrender either an illegal gun or a legal gun, for example, a 3D printed gun?
These issues around who can store guns outside the home, the transfer of a gun, which is a legal matter, is different in every single state. And so you actually have to learn from your local gun-owning leaders and police how that works in your particular county or your state. I will say, though, there are many informal things that are happening where a buddy approaches their friend who's at risk and says, simply, can I hold it for you for a period of time? So those things do happen in informal ways. I will say that one thing that I didn't get to speak to that I think was a question that came up was around extreme risk protection orders, which is a legislative mechanism which is that these ERPO or red flag laws are being passed all over the country, and AFSP is hugely supportive of them if there is due process, because we do want to protect the individual to have an appropriate. You can imagine how that could get misused in cases of divorce or other matters where it could be abused. So when certain things are in place, that is a policy mechanism that AFSP and other suicide prevention organizations are very, very supportive of, even while we're partnering with firearm owning organizations, retailers, range owners to promote suicide prevention education. So you can work both angles in terms of education and partnership, but also the policy areas where you can protect someone. And what a red flag law allows for is if someone is in fact shown to be at risk of self-harm or harming others, then their gun can be taken from them temporarily while they are in that period of at-risk behavior.
Thank you. So, and this is specifically to you as well. You said that accidents are still the #1 cause of death for youth, but my understanding is that if it is unclear whether a youth death was an accident or suicide, then it is a data point counted as an accident not a suicide. Can you comment on that?
That is correct, and that is a problem in our suicide surveillance system. And if you think about the opioid crisis and the number of deaths by opioid and other substance overdose, certainly it's estimated that probably between about 10 and as much as 25% of those could have had a suicidal component and not be accidental overdoses. But when there wasn't a specific way for the coroner or the medical examiner to determine that, it is simply called an overdose and not a suicide. And the same thing for motor vehicle accidents and other types of, accidental deaths, where that's where I think there's a lot of advocacy around tightening up surveillance and getting much, much better at that. I mean, one weird, really wonky thing in our system is that some counties, their death investigation system is led by a non-medical person, a coroner, who is an elected lay person without medical training. In other counties, it's a medical examiner who is an MD. So you can imagine, and there's actually a study that showed that coroners' counties were more succumbing to social pressure of, let's say, a prominent family or something to not call it a suicide. So, those are all moving targets, and we certainly know that cultural factors can play a role too, where in Black and Hispanic communities, Asian communities, there is, in a way, more stigma, and where deaths that are uncertain are less likely to be called a suicide, and that may be improving, in terms of the accuracy, which could account for some of the rises in suicide rates, but probably not all.
And so just so Dr. Stephanie Fiore in our county, and which one of you had data? County Andrea. So we're going to have our Integrated Behavioral Health Action Coalition. We'll have our next meeting June 2nd, specifically on suicide in Santa Cruz County. And at the SafeRx table, we have a little flyer about that. So if you'd like to be invited to that meeting, please just take a picture of the email. It's maria@hipscc.org. And we'll work with Dr. Fiore to get more data around suicide. There's another question around data that relates to our older members of our society. So you had shared the data point that showed that we have an increasing group of suicides from people 60 and older. And there are actually a number of questions about medically assisted suicide and compassion in dying, which we have in the state of California. Do those ever get counted when they're an intentional death? Do they get counted as a suicide? And tell us about how that goes in California, if you know it.
Well, that probably varies county to county, again, because of those differences in who leads the death investigation system in various places. But my general sense is that, first of all, the numbers of people who have died by aid in dying, physician, aided suicide, that those are very, very small numbers compared to the number of people who die by suicide as we understand it. And I will also just say that at AFSP, we had to kind of wrestle this to the ground at one point, how we were going to view aid in dying type deaths. And we have, after bringing in experts over a couple years of extensive sort of analysis, we've kept it in its own separate category. We think there are separate issues for terminally ill people, and that's a separate matter.
That's good. Yeah. Thank you. And so several people asked about the good behavior game and wanted to know a little bit more about it. And I think we don't have time for you to explain it at length, but if you can do a summary and maybe other suggestions, because they love that.
Yeah, it is a really neat approach, and it's been replicated outside of Baltimore as well. If you want to read more about it, the lead researcher on that study, her name is Holly Wilcox, out of Johns Hopkins University. So just look up good behavior game, Holly Wilcox, PhD, and you'll see a little bit more a description of that classroom management system itself. And it's not that it has anything magical. It's really any approach where there is an emphasis on the practical ways in the moment, but with a long game view. So this isn't just, drop in and play this game. There was a whole training for the entire school staff that organized around implementing it as part of an approach, a framework. It's, in a way, it's kind of like, I think about the framework of trauma-informed care, but if you've ever heard of the film called Paper Tigers, that was about trauma-informed education, and in high-risk settings for youth who were in alternative schools and so forth in Walla Walla, Washington, the phenomenally different results when the staff, instead of assuming that behavior required discipline, that then instead they started understanding that trauma can produce behavior changes, and trying to get to the root of that, going to the home, learning more about what's happening with mom and dad and what's happening in the home, and some support around that, and really turning some very dismal results around into some very positive results. So it's kind of like that, where it's quite comprehensive, I think. I actually think the good behavior game is probably a little simpler than the trauma-informed part.
Got it.
Just real quick,
Yeah.
If you Google good behavior game in quotes, they have an awesome website that will give you lots of research information about it, as well as kind of what's entailed and how to get hold of the people who can get you more information or get you a copy of it.
So I'm very aware that we have like 1 to 2 minutes, and I sort of want to do a few more quickies, but I really want to acknowledge there were a lot of questions and comments about not enough clinicians that in the schools and in our community to address mental health and behavioral health. And so it kind of feels like I'd love to see a follow-up for this, to like, this is a mental, I know the county's doing it all the time, but we really need more engagement. I know that our county does reach out, has community forums, and asks for feedback from the community, but clearly this is something that's a huge problem, both in the schools and in the community. There were several questions about how to do suicide assessments, how to get training on suicide assessments. I think you had those as resources at the end of your slides. So for those of you who asked that, please go to the slides that Christine had. Very quick question, what is your suggestion for verbiage for the PHQ to incorporate the suicide factor? Or is that too long? That may be too long.
My suggestion is to not use the PHQ-9 as your suicide screening tool.
So use the ASQ?
You actually have to start using a suicide screening tool like the ASQ or the Columbia.
And does the ASQ work for the perinatal population?
Oh, for postpartum and
or pregnant and post?
Yes, it does.
Or is there a better one? If you're pregnant?
There is not a better one.
Okay,
for women and pregnant women. And
so
postpartum.
I think my clock says 4:01. I apologize, but thank you to our panel. Awesome.